Hi everyone, my name is José Carlos Martins da Rosa. I'm from Brazil, and first of all I would like to thanks for the opportunity to be here and thanks for the invitation, and special thanks to Dr. Peter Norland, who is responsible for my presence here today. I will talk to you about immediate dentoalveolar restoration with long-term follow-up, the preservation and regeneration of the natural biology. And here we have a clinical case. We have the fracture of the second premolar. We have an infection right here. We have the tissue shrinkage at the dental site. After we remove this fixed prosthesis, you can see two different scenarios. And the main difference is about the buccal palatal distance of these two different areas, a dental site and post-extraction socket. And according to my experience, a post-extraction socket would never become an dental site for late implantation. It's because it would increase the number of the procedures, the cost and the treatment time, and of course the unpredictability of the outcomes. That's why I recommend you that everything is going to be solved in one single procedure, applying flapless surgery. Remember that the dentist is responsible for this decision making, not the patient. In the second premolar area, we have a huge defect, and the IDR technique fits perfectly what we are looking for. It's all based on biological response. It's a bone grafting at the time of immediate implant placement and provisionalization in compromised alveolar sockets. And our goal is the preservation and regeneration of the natural biology. This was our first IDR clinical case. The hopeless tooth was the right central incisor. You can see the abscess at the buccal aspect. The tooth was extracted. We evaluated dimensions of the defect. We insert the implant, the correct dimensional position, and we graft this area with autogenous bone graft harvest from the maxillar tuberosity. And we fully filled these gaps with particulate bone, and it was made the provisional restoration immediately, of course, out of occlusion. 4 months later, we have the maintenance of the anatomical contour of soft tissue. At this moment, it was taken impression, it was made the final restoration. This is the post-op after 15 years. We have the maintenance of the thickness and height of this new buccal bone wall and the maintenance of the gingival architecture exactly in the same position. We have already performed more than 600 clinical cases which presented bone defects involving one wall, two walls, three walls, or all walls around the condemned tooth. Our goal today is to answer this question with you: how to get hard and soft tissue stability in one single procedure using flapless surgery. This is what I recommend you, that the IDR technique fits perfectly what we were looking for in the treatment of compromised sockets. This is the IDR science, the IDR articles. We have already published 28 articles about this topic. The first article was published in 2008, and since then we have published many different other articles in different journals worldwide. Let's see some of the clinical applications of the IDR technique. Let's start talking about a case that presented the leveling of gingival margin using cortical cancellous graft to restore the defect. This patient came to us several years ago. She presented the right central incisor condemned to extracted. She presented pain in mobility in this tooth. We have here the loss of the buccal bone wall. The tooth was extracted. We confirmed the total loss of the buccal wall. The implant was placed in the correct dimensional position at the palatal wall anchorage, and we left the gap around 3 mm at the buccal aspect. It was made the provisional restoration using the same crown from the patient, and we relined the cervical area with composite resin. And we left intentionally what we call a soft tissue gap, an under contour, a concave contour at the buccal aspect and the proximal areas to promote a soft tissue ingrowth and better soft tissue accommodation. This is an article that was published by my team, the protocol for selection of implant diameter in post-extraction socket in 2014. Always expect a gap around 3 mm regardless of the tooth to be replaced. Anterior, posterior, upper or down, doesn't matter. And we use this very simple mathematical rule. The implant diameter is equal to the buccal palatal distance of the socket minus 3. This is another article that was published in 2016 by IJPRD. Here we did a clinical research and we applied this methodology, a gap of 3 mm in intact socket and compromised socket. And we evaluate the most important area of the implant, the corneal third of the implant, in a mean of follow-up of 3 years. And we evaluate the maintenance of the thickness of bone grafted and incorporation, up to the implant platform 2 millimeters above and 4 millimeters above. To harvest bone graft from the tuberosity, we need previously a clinical assessment, an X-ray, and a CBCT from this donor area. These are the tools that we use to take bone from the tuberosity, the IDR chisels, and the chisel has to be placed as perpendicular as possible to the bone structure. Right after, to go deeper, approximately 2 or 3 millimeters, the chisel's angulation is modified according to the desired size and width. After going until the planar length, the bone is fractured, and we use this double layer graft, a corticocancellous graft, to restore the bone architecture. And we also match the cervical portion of the graft with the outline of gingival margin in order to restore the bone architecture. And we harvest more bone in order to be crushed, and we fill this gap with particulate bone, and we left bone graft 1 millimeter over the implant platform. So the implant was placed 3 millimeters from gingival margin in the apical direction, and the graft 1 millimeter over the implant platform. And we start the provisional restoration immediately and out of occlusion. Let's have a look at this illustration to understand better this concept. The implant was placed, we made our provisional restoration, and we use here a buccal corticocancellous bone graft to restore the buccal wall, plus particulate bone graft as a bone filler that is going to be inserted between the cancellous part of the graft and the implant surface. And we left intentionally what we call a soft tissue gap that's going to be filled with blood clot that comes from the socket, from the graft, and from the periosseum of the remaining bone. Take a look what happened with the soft tissue. The soft tissue has been changed in the coronal direction. Just obey the orders. We change the position of the graft, and the soft tissue changed in the coronal direction. After 3 months to push the soft tissue in the apical direction, we added composite resin 0.5 millimeters a week for 2 or 3 weeks. After we got it, we evaluate first the maintenance of the papillary height and the maintenance of volume of soft tissue. So it was taken impression, it was made the final abutment, zirconia abutment, and we cemented the final porcelain restoration. And this is the post-op after 6 years. The clinical follow-up, you can see the maintenance of the anatomical contour of soft tissue and the maintenance of the thickness and height of the bone grafted. So I can say that if we have around 3 millimeters of bone at the buccal aspect, we do not need to compensate with soft tissue graft. Let's have a look at the second clinical case that presented large gingival recession. In case like this, it's mandatory to use a triple graft. It's a little bit different than the other graft that we discussed before, because this graft has connective tissue along with corticocancellous graft and one single piece harvest from the same donor area, from the maxillar tuberosity. This was the first article in the international literature published by my team in 2009, and we suggested a new way to manage hard and soft tissue damage using triple graft from the maxillar tuberosity, using this concept: tooth extraction plus implant plus triple graft plus immediate provisionalization, all in one single shot. Let's follow this case. The hopeless tooth was the right central incisor. We have a gingival recession around 4 millimeters in height. This is a patient with a high smile line, and she lost completely the buccal wall. So the tooth was extracted, and you can see here how thin the soft tissue is. You can see through the gingival the periodontal probe. So the implant was placed 1 millimeter from gingival margin in the coronal direction. It's because you have to compensate the biological width using a triple graft. It was made the provisional restoration with ideal emergence profile, and we left here what we call a soft tissue gap. So it was harvested from the maxillar tuberosity, a graft with 3 layers: connective tissue, cortical, and marrow bone, and one single piece. If we do as we did in histological section, we can clearly see here the connective tissue, the periosseum, the cortical, and plus marrow bone. So we have 4 sources of the nutrition ready to be transplanted from the donor side to the receptor side. How is the ideal position of the triple graft? The ideal position is leaving the connective tissue layer turned toward the soft tissue and the cancellous part of the implant body, but in between we should insert particulate bone as a bone filler. 1 stitch was enough to hold the graft in the right position, and 2 more stitches in each papilla, and pay attention that we left the outline of gingival margin at the same level of the gingival margin of the opposite side. After 3 months, after hard and soft tissues being healed, we noticed that the biological width was retrieved. We have now 3 millimeters from gingival margin to the head of the implant. And pay attention also the increasing volume of soft tissue. It was taken impression, it was made the final abutment, but have a look at the outline of gingival margin, very similar in both sides. We deliver the final porcelain restoration, and here you can see the biotype conversion. We have a thin periodontal biotype, and now you can see a thick periodontal biotype. The final outcomes, we have the balance between gingival margin and papillary height position. Just make a comparison how everything started. We have a breakdown in aesthetics, and now you can see the balance between the lips, the gingival architecture, and the final porcelain restoration. And this is the CBCT scan that was taken after 11 years. You can see the maintenance of the thickness and the height of the bone grafted, completely remodeled and still stable after 11 years. To finish my speech, I would like to share with you a case that we have several periodontally compromised teeth. Is it possible to do it all in one single procedure? Here you can see many periodontal condemned teeth. Through the CBCT image, we notice the number of condemned teeth in the maxilla, 8 teeth in the maxilla plus 2 more teeth in the mandible. And we decide to keep both canines in the upper jaw and the upper left first premolar. The day of the surgery, we extracted tooth, applying minimally invasive procedures, and we install the implants in the correlative dimensional position, always expecting a gap around 3 millimeters at the buccal aspect. Here, after we finish this task, after all the implants were placed in the right position, as you can see, and we also did the teeth extraction plus the implant installation in the lower jaw, exactly at the interdental septum at the first molar position. We went in the tuberosity and we harvest from both tuberosity, the right and the left side, bone graft using chisels, handle instruments, as you can see here. And the image on the right, you can see right after we finish the suture. Pay attention to the size of these block bones that we harvest from both tuberosities. And I recommend you to read this paper that was published by my team and Dr. Georgios Romanos' team from Stony Brook University, the role of the maxillar tuberosity in periodontology and implant dentistry. It was published in 2019. And we split this tuberosity in 2 halves. The first half, we reshaped the graft according to the defect configuration, and the other half, we crushed in order to reduce the size of these particles. And inside this container, we have all we need to promote a faster and better bone graft incorporation. We have bone and we have blood. And we start bone reconstruction, 3D bone reconstruction to restore the buccal wall, the palatal wall, the mesial and the distal bone ridge in all of the sides. After we finish this task, you can see here the bone graft all around the body of the implant. And we use flapless surgery, not only in the post-extraction socket, but also in the dentular side as well. And we install the fixed prosthesis in the upper jaw, 3 fixed prostheses and 1 more fixed prosthesis in the lower jaw. And the sutures only in the donor side. And everything was solved in one single procedure. This is the immediate post-op, no pain, no bleeding, nothing. And 3 months later, after soft tissue is completely healed, we remove this provisional restoration. Let's make a comparison of the steps right after the extraction, after implant installation and bone reconstruction. And after 3 months, we have the improvement at the buccal palatal dimension of this peri-implant partition in all of the sides. And we have again a biotype conversion. We start with a thin periodontal biotype, and now you can see a thick periodontal biotype. Now, how about the behavior of this graft in the lower jaw? Have a look that we have the same outcomes. We have the maintenance of the anatomical contour of soft tissue and the improvement in thickness of soft tissue at the buccal aspect of these 2 implants and the maintenance of the papillary height and volume. So here you can see the simulation right after the extraction in the anterior zone, after implant placement and bone reconstruction, and 3 months later we have the maintenance of the volume and the anatomical contour of soft tissue and the papillary height position. Here you can see through this CBCT scan, the bone completely remodeled and is still stable at the facial, and the palatal aspect in all of these implants. So in the day that we deliver the final restoration, you can see a very nice relationship between the cervical area of the final restoration and the gingival architecture. So what aesthetic outcomes do patients want today? So remember that the perfection is in the details. Just make a comparison before and after 3 years. We still have the maintenance of the gingival architecture all around the single crowns. As you can see here from the occlusal views, we manage these cases with single crowns in all of the sides. So what are the main advantages of using this concept, the immediate dentoalveolar restoration technique? First of all, the preservation of the natural biology. We use this graft as a biological membrane to prevent cells competition between hard and soft tissue. The maintenance of the gingival architecture, we only use a flapless procedure. The improvement of the gingival thickness, as you saw before, the biotype conversion. The reduction in the number of the interventions, we use a single surgery. And the reduction in the treatment costs. We only use autogenous graft instead of use any kind of other graft. And we know that's a technique sensitive that it demands training. That's why we developed more than 10 years ago an IDR hands-on course. This is the global training. The next edition of the IDR hands-on course in US will take place at Picos Institute next year at Tampa, Florida, with a 6-day course to know everything about the IDR technique. As soon as you finish the course, you are ready to apply this technique in your patient's mouth. If you want to have more information, go to Picos Institute website. This is a new platform, IDR Online Education. This is a 2-day recorded course. The 23 main topics on IDR is discussed more deeply in this course. You have lifetime access and you can watch at any time. If you want to have more information, please go to picosonline.com. All about the program, all you need to know about this course is described in this website. So thank you very much for your kind attention and for your patience. And I hope to see you soon in person.